Subclavian steal syndrome. It occurs due to occlusion or severe stenosis of proximal subclavian artery. Remember, proximal subclavian artery. It results in retrograde flow in the ipsilateral vertebral artery. Remember, vertebral artery is a branch of subclavian artery where there is proximal subclavian artery occlusion or stenosis. At that site only, means the ipsilateral side vertebral artery will show a retrograde flow. Let's draw the diagram. This proximal subclavian artery is occluded or severely stenosed, therefore no flow in the subclavian artery. Now how will this flow be achieved? From the opposite side of the vertebral artery, flow will go up and it will come down to the ipsilateral side of the vertebral artery. This will supply the subclavian and artery blood flow or the arm blood flow. Therefore, subclavian is stealing the blood from the vertebral artery, known as a subclavian steal syndrome. Let's see the causes. First is the atherosclerosis, which is causing severe occlusion, vasculitis, thoracic aortic dissection, Blalock Tosin shunt. Some congenital causes like interrupted aortic arch, preductal aortic coarctation of the aorta, right aortic arch with isolated left subclavian artery. The male to female ratio in subclavian steal syndrome is male greater than female in the ratio of 2:1, and left side is more common than the right side. What are the clinical features? Since subclavian artery is stenosed, so unilateral or ipsilateral weak absent pulse, decreased blood pressure or arm claudication. Since vertebral artery is stealing, therefore neural symptoms like dizziness, vertigo, syncope, ataxia, visual change, weakness and sensory distress. Now let's discuss the radiological feature. USG is very important initial step. What is the normal vertebral artery Doppler? There will be well defined a peak, systolic peak. Sustained flow will be seen in diastole, and the PSV or the peak systolic velocity will be 20 to 60 centimeter per second. Let's draw the diagram. The baseline we have drawn. There is a systolic peak, a very sharp systolic peak, and a flow through the diastole and then touching the baseline. Let's see the image, the USG image. Here we can see that there is a vertebral artery and vein is showing flow through the Doppler imaging, and if we place a spectral waveform on the vertebral artery, we see the normal waveform where there is a sharp systolic peak and continuous or sustained flow through the diastole. This is normal vertebral artery waveform. Now let's draw the diagram in the image. The yellow part, a peak systolic, well-defined peak of systole and a flow, continuous or sustained flow through the diastole. Therefore, through USG, we can see the flow through Doppler, and if we put a spectral waveform, we can also diagnose the obstruction. Therefore, USG is very important in cases of subclavian steal syndrome. Now let's see what happens in subclavian steal syndrome. We know from the diagram that there will be retrograde flow in ipsilateral vertebral artery, and this vertebral artery, when put waveform, there will be decreased velocity and in the change in the waveform because flow is reversing, and these changes can be augmented by arm exercise or inflating by the blood pressure curve because subclavian steal. In the proximal subclavian artery, we will see stenosis, and in the distal subclavian artery, we will see Parvus-Tardus waveform and a monophasic flow pattern. Remember, if we see Parvus-Tardus waveform, it indicates that upstream obstruction is there. Means if you see a parvus tardus waveform, that means somewhere along the course of the blood flow, above where you will see parvus tardus, above it there is a obstruction happening. Now let us see in the image. Here we can see that one of the vertebral artery is in red color, whereas the other is in blue color. The one waveform is above the baseline, whereas the other vertebral artery, the waveform is below the baseline. That means one of the vertebral artery is showing reverse flow, which is the first sign that there will be reversal of flow in the ipsilateral vertebral artery. This can also be seen if we can compare vertebral artery with the ipsilateral carotid artery. Suppose both the carotid artery and the vertebral artery normally takes the blood from the heart to the brain, but if there is subclavian steal syndrome, then internal carotid artery will take the blood to the brain, but ipsilateral vertebral artery will show reversal. Therefore, there will be a difference in the flow in the internal carotid artery and vertebral artery. Therefore, we can compare either both the vertebral artery to see the blood flow, or we can see between the vertebral artery and the internal carotid artery on the same side. Now, if we put the waveform in the vertebral artery in subclavian steal syndrome, what we see? First, let us see the normal, which we have drawn on the right side of the image, yellow diagram. Now, when we see in the subclavian steal syndrome, we can see it is the diastolic part is going below, whereas the systolic peak is not sharp. It is the PSV has decreased. It is going below the baseline. Therefore, biphasic pattern is seen. These are the changes which we will see in the waveform in the subclavian steal syndrome. Normal vertebral artery waveform is sharp systole and a continuous flow through diastole. That is normal. But what happened in parvus tardus? It is slow to rise and a small peak. That is parvus tardus waveform. It means that upstream of the blood flow there is obstruction. Let's see there is slow to rise systole and the peak is also small. That is parvus tardus waveform. Suppose the stenosis is not that severe, it is moderate. Now what will happen? Now note that only in peak systole the flow will be reversed. Now why in peak systole only? Because the difference in the pressure is there in the peak systole. Therefore, it will go down. The peak will go down, which we'll see in the red part of the diagram. Now if we'll see the diagram, on the right side we can see the normal waveform, a sharp systole and a flow through the diastole. But in the peak systole, it is going down the baseline. That is that this stenosis is not that severe to cause the changes which we have discussed. But this is the change that in the peak systole it has gone to the baseline and then come up and then flow through the diastole. This is given the appearance of rabbit ear. Other modalities are CT angiography, where we see the subclavian artery, the proximal part of the subclavian artery is occluded or severely stenosed. There is delayed enhancement of the ipsilateral vertebral artery because it has to come through the opposite side and then get filled. And the direction of the flow of the vertebral artery cannot be determined as compared to in USG, where we were able to determine the direction of flow. Here in CT we cannot determine. Same findings which we can also see in MRI angiography. In the DSA or digital subtraction angiography, simultaneous treatment can be done and direction of flow can also be noted. This is CT angiography image. We can see the yellow arrow is pointing that the proximal part of the subclavian artery is not completely filled with the contrast. It is severely stenosed or occluded.